Good afternoon, my name is David Denning. I'm very sorry that I'm not with you in Accra today on the World Aspergillosis Day, which is a big event for us every year. What I'm going to try and do today is to explain to you, as best I can, something about how we make a diagnosis of chronic pulmonary aspergillosis and how we treat it, and also about the differential diagnoses that are relevant to it. So I'm going to start with my first slide. And I'm speaking today from Manchester in the UK, where we run the National Aspergillosis Centre, and we have a lot of patients with chronic pulmonary aspergillosis that are referred from all over the UK, typically about 120 new patients a year. And we also look after a lot of patients with allergic fungal disease and many other infectious diseases. We have a transplant service on site and do ECMO as well, and that's an important part of the infectious disease consultation that we do in the hospital. As you may know, there's been a new organisation set up in Ghana, the Fungal Infections Care in Ghana, which I'm really glad to welcome into the world of mycological associations. We just wrote a paper from Nigeria showing that actually having an association and a focus on these diseases is very valuable for patient care. You can divide fungal diseases into 5 broad categories. There's mucosal disease, which is typically oral or vulvovaginal candidiasis. There's the commonest problem worldwide is cutaneous disease with athlete's foot, onychomycosis, ringworm, tinea capitis, and so on. Then there are chronic fungal infections, which I'm going to speak about one of these today, but there's also mycetoma and chromoblastomycosis, which are neglected tropical diseases. There's also a lot of patients around the world with allergic fungal disease, particularly allergic fungal sinusitis and ABPA complicating asthma. And actually asthma is made worse by fungal sensitization, which is relatively common but not well documented in Africa. And then invasive and life-threatening fungal infections, Candida bloodstream infection or candidemia, invasive aspergillosis and cryptococcal meningitis, particularly in AIDS, are also very important. Collectively, these infections lead to about a little over 1.5 million deaths a year, a very similar number to tuberculosis. We think some of the patients who apparently die of tuberculosis actually die of fungal disease, but the diagnosis is not made. Malaria deaths have been coming down a lot. They're still much too high, but it's important that disease is also addressed. But if you consider how much emphasis is put into TB and malaria, they are much, much greater than fungal disease, which is rather minimal. Now, fungal diseases complicate other diseases for the most part. So cancer patients get aspergillosis, candidiasis, pneumocystis pneumonia. Patients with AIDS get pneumocystis and cryptococcal meningitis, and also histoplasmosis, which is well recognized in the Americas, but not quite so well recognized in Africa. Chronic pulmonary aspergillosis affects those with bad lungs, particularly those with TB, but we see this in the patients who have TB and HIV infection, but also patients with COPD and asthma. And also fungal asthma complicates asthma, makes it worse, as I mentioned. And then there are a number of diseases which are important and numerically important and clinically important, which affect normal people. So fungal keratitis, over 1 million cases a year, and some quite good work in Ghana on this from some years ago. Tinea capitis, which is particularly common in black children in Africa, but is seen worldwide. And mycetoma, which is well documented in Sudan, but is again a worldwide problem in the tropical areas, chromoblastomycosis and sporotrichosis, which are also worldwide problems. But these are in apparently normal people. So today I'm going to focus on these chronic fungal infections, and particularly chronic pulmonary aspergillosis. Now this slide, this patient's X-ray series, illustrates why we had to think about this disease a bit differently. So here's a woman in her 30s from Ireland who's a smoker with an abnormal chest x-ray that I'm sure most of you would be comfortable diagnosing bilateral upper lobe tuberculosis in. There's perhaps a little bit too much pleural thickening on this side for typical TB, but otherwise it fits quite well. She was treated for TB, although the diagnosis wasn't made, and a year later her chest x-rays changed a lot, and it doesn't look like TB now, but it isn't quite clear what is wrong with her. So she has these upper lobe, a big upper lobe cavity here and another one here, and this persistent pleural thickening or opacification. And a year later, you now see that actually she's lost a lot of her upper lobe. She has a small fungal ball on the left-hand side and two obvious cavities on the right-hand side with this area of consolidation, which is not homogeneous. And a few months after that, you can now see that she's got a fungal ball on this side. And this is a completely normal woman, apparently. There's clearly something wrong with her immunologically, and this is all aspergillosis. And so if you look back 20 years, this x-ray doesn't fit anything, did not fit anything in the literature. You haven't got an aspergilloma, simple or complex, it isn't tuberculosis, and what is it? And so the terminology had to change, and that's why we ended up with this terminology of chronic cavitary pulmonary aspergillosis, which is very like the terminology for histoplasmosis. Now, most patients have multiple cavities. Occasionally, you have patients like this one who has sarcoidosis and one large cavity with pleural thickening there and a single cavity, but that's uncommon. Occasionally it's the case, and these patients, all these patients cough up blood, and often quite a lot of blood. And while that's can be seen in tuberculosis, in fact, usually in TB there's only a little bit of blood, whereas the patients with chronic pulmonary aspergillosis cough up really quite a lot, and they can die of coughing up blood. So sometimes the x-rays look like TB. So here's an example where, in fact, it's not quite like TB, but you've got pleural thickening in a single cavity, but it would be easy to ascribe that to TB. In fact, this patient has never had tuberculosis, just has aspergillosis. And you have other examples, and this is an example of an AIDS patient with upper lobe cavitation, which would definitely fit for tuberculosis, and this patient did not improve on antituberculous therapy, and we put a needle in and did a percutaneous biopsy of this lesion here and had a pure growth of Aspergillus, and the patient improved a lot with antifungal therapy. In fact, went back to being normal with antifungal therapy. So it can be a subtle diagnosis, and there is a differential diagnosis, and aspergillosis in AIDS is often missed completely. This is an autopsy series from Italy, and although some of these numbers are fairly small, you can see they almost always made the diagnosis of cryptococcal disease, and about half the time got pneumocystis right, but very few of the patients with aspergillosis actually were diagnosed accurately. And this is because of the diagnostic tests which are not available, but also clinical suspicion. So here's another example of an X-ray or scan, and I think if you were to see this scan, you would probably diagnose tuberculosis, and the differential diagnosis includes that, TB, plus also non-tuberculous mycobacteria. But in fact, this is all aspergillosis, and these very thick-walled cavities are typical of aspergillosis, but they're not specific enough to know the answer without doing diagnostic tests. That's in contrast to this scan, where you have a contrasting cavities. So here you have a nice smooth-walled cavity, and this patient had had Mycobacterium avium disease, and this is healed completely. And on this side you have a cavity with a lot of pleural thickening and a lot of material within it, and that is highly typical, highly characteristic of Aspergillus. What you've got is Aspergillus growing inside this cavity, and it's causing disease, an irritation of the lung, inflammation of the lung. And if you were to open that cavity, as was done in another patient, you can see the Aspergillus growing on the surface of the cavity like that, and microscopically you see all these hyphae. So this illustrates it in a different way. Here's a man originally from India with an obviously abnormal right upper lobe with a lot of pleural thickening and cavitation. And he'd had TB twice, documented and fully susceptible and fully treated. And then he came back with new shadowing. This time his TB tests were negative. He had a little bit of cough, but he was working very hard. He was a builder. But he had a very high Aspergillus IgG antibody test, 190. So that's a really strong test. No inflammatory markers were abnormal. And then he went on to have a CT scan. And you can see this remarkable pleural thickening, which is not so common for TB. In fact, I'm not sure it's a big feature of tuberculosis. Small cavity and multiple cavities here. And so this is sort of suspicious of TB, but not typical of TB. And they were worried about whether he had a tumour. So they did a PET scan. And I realised you wouldn't normally see a PET scan, and we don't normally do them for this disease. But it illustrates something very helpful in this patient, and that is that the inflammation in the pleura here is lit up. So despite a normal inflammatory markers, a patient who's got very few symptoms, you've got a lot of inflammation in this patient. And that is what's going on in chronic pulmonary aspergillosis, this sort of slow chronic inflammatory process leading to fibrosis. Now, the differential diagnosis, as I've mentioned, is quite broad. You've got TB, you've got NTM infection, and you've got chronic pulmonary aspergillosis, and those are by far the three most common causes of this upper lobe cavitation. We do, in India particularly, there's quite a lot of patients with ABPA that present with plugging of the airways, and that can look a little bit like CPA. Lung cancer, particularly in smokers, but not exclusively in smokers, is important. There are some cavitating bacteria, Pseudomonas, Staphylococcus, Rhodococcus, and Nocardia, usually in immunocompromised patients, but occasionally not, and actinomycosis. And if patients have travelled a long way, then you can get histoplasmosis or coccidioidomycosis, or even from Brazil and other parts of South America, paracoccidioidomycosis, although they're rare. So here's an example of chronic cavitary pulmonary histoplasmosis from Argentina. He was a truck driver, a smoker, and a drinker. It's not really acceptable to be a drinker and a truck driver, but that was the situation in this man. And he'd been treated for TB twice, not improved, and he was very hoarse, and so they did a laryngeal biopsy and they found granulomas on that. Of course, that's consistent with TB, but they then did special stains for fungus, the GMS or Gamori methenamine stain, and they could see very small yeasts which are typical of histoplasmosis. And they then did his histoplasma antibody, and it was very strongly positive. And you can see that this disease is not too dissimilar from some of the other x-rays I've showed you. It's not a brilliant quality film, but that's where it is. Now, so this slide sort of summarizes where these diseases fit. Okay, so you've got Aspergillus along here, and it causes all the different sorts of disease. Blastomycosis, which we haven't talked about, disseminated in AIDS, and you can get acute in normal people. Cocci, disseminated in AIDS, there's a nodule, and there's primary disease in normal people. Cryptococcus that causes pneumonia in normal people and immunocompromised people. Histoplasmosis with the chronic cavitary form, and paracocci with that form. Whereas Aspergillus, you have invasive disease in different sorts of patients, chronic disease, acute community-acquired pneumonia, which is rare but does occur, bronchitis in those with airways damage, and fungal asthma and ABPA. So it's a broader spectrum of disease. Now, what happens to patients with chronic pulmonary aspergillosis. So some cough up blood, some just are progressively ill and unwell with weight loss, with very tired, coughing, short of breath. And some of them get very short of breath because they go on and get fibrosis. And here's a lady who originally from the Gujarat in India who had tuberculosis and cured, and then developed new shadowing with cavitation in the left upper lobe. And you can see that over 2 years this progressed a lot. She's lost a lot of her left lung here, and she's developed a fungal ball here. And then 3 years after that, she's lost the whole of the left lung. So this is chronic fibrosing pulmonary aspergillosis, this very slow progression. And not all the patients do that, but the majority will do something like this over time. And sometimes the fibrosis is quite rapid. So it can be, nothing can happen and the patients appear fine, and then fairly quickly, in the space of 1 month or 3 months, you get fibrosis. And so it's one of the reasons why we like to treat patients and keep them on treatment if we can. So in 2016, several people with expertise in this area from Europe wrote a series of guidelines, the first time that these have been written. And the first recommendation on those guidelines was that the radiologists should report a suspicion of aspergillosis in those with cavitation, fungal ball, pleural thickening, or upper lobe fibrosis. At the moment, too many radiologists just report the morphological features, so they can say atelectasis or pleural thickening or something, but they don't mention Aspergillus. And they need to mention it because then the clinician will think about it. Otherwise, the clinician will usually just treat for tuberculosis or look for tuberculosis. So there's basically one differential diagnosis, and you can broaden that as a radiologist by requesting this. Now, in fact, we've got there are 4 broad categories. There's also an Aspergillus nodule that I'll show you a picture about. Some patients have very limited disease post-TB, and these patients are surgical patients. This can be operated, but if they have bilateral disease, it's not appropriate. We've talked about chronic cavitary disease and chronic fibrosing disease. So the nodules, which are usually not so easy to see on a chest x-ray, but are visible on scan a bit more easily, maybe multiple, maybe single. They usually are cavitating like this, but they may not be. So you've got examples here, small ones like this. And they're slightly more common in people who've had steroids with COPD or asthma and steroids, but they can occur in other contexts. And they look like lung cancer, and if you do a biopsy, you can find Aspergillus in them. Now, we've been interested in how common this infection, chronic pulmonary aspergillosis, is in Africa. And in Gulu in northern Uganda, we started a study which is just now in press, which I'll show you the results of. This is the referral hospital in the north of the country, and these types of appearances of patients and the sunny area will be familiar to you. These were the prisoners being walked in to have their HIV therapy. And we looked over a 2-year period. We started with 400 patients, and we had 285 that made it for the second visit, about half HIV positive, half HIV negative. And we found chronic cavitary disease in a total of 10 patients, fibrosing disease in 3, 1 with a simple aspergilloma. And we had some patients who we didn't have antibodies positive, or we didn't have a CT scan to confirm the disease. And so the rate, we think, in this population is about 5% or maybe as high as 6%. But what's really interesting is that if you take patients who have cavitation at the end of their TB treatment, then 6.5% went on to get chronic pulmonary aspergillosis. If you take those who had no cavitation, only 0.2%. So I don't know whether it's your practice to do a chest x-ray at the end of your TB treatment, but I think that would be a useful thing to do given these data, because you might then want to follow the patients who've got cavitation at the end of treatment to see what happens to them. And if they haven't got cavitation, you may feel comfortable discharging them, because you're only going to have 2 in 1,000 based on this data that go on to get disease. But in this group, you're going to have about 1 in 13 that will go on and get disease. So how do you get to the diagnosis? Many of these patients cough a lot of sputum up. Here's an example with a very thick pleura and a fungal ball within it. The problem we have is that fungal cultures are not very sensitive. So we only, between 10 and 40% of patients have a positive fungal culture. And that's one of the reasons the fungus and the diagnosis is missed a lot. Now, if you do a high volume culture, so you plate the whole of the sputum, you can get a higher yield. And this is examples of what those culture plates would look like. And we've done some work just retrospectively in our patients here, where if we send the sputum to the routine lab, we have about a 15% positive rate. If you do a high volume culture, it's nearly 50%. And we also do Aspergillus PCR, and that's about 50% as well. And these are not the same patients. So if you stack this bar here, you get to about 70 or 80% who you can pick up the fungus. And some of these patients are on treatment. These are on treatment, and so these are patients who may have antifungal resistance, and we then do further work on those. So the culture is not very sensitive, although you can improve it with a high volume system. It's still not very sensitive. About a year ago, 2 years ago, we had a meeting, and last year we published this algorithm to try and make a diagnosis in patients in resource-limited settings. And so you have patients who have cough, hemoptysis or weight loss for 3 months, and they get a chest x-ray. If that's normal, then you might have bronchiectasis or something else. If you've got consolidation, that's very unlikely to be chronic pulmonary aspergillosis, so you've got something else. But if you have cavitation, pleural thickening, fungal ball, or pericavitary fibrosis, that's highly suspicious of chronic pulmonary aspergillosis. So you've got to exclude tuberculosis, and many of these patients will have TB, so with a fungal smear or a gene expert test, and if that is negative, then they need an Aspergillus antibody test. And most of these are positive in patients, but they're not all positive. So even a negative test, you need to look at the sputum, if you can get it from the patient, to look for microscopy and culture. And if they're positive, they're likely to have chronic pulmonary aspergillosis, and then there's a discussion about whether they can have surgery or not. So the Aspergillus antibody test comes in lots of different formats. This is a modern, about 20-year-old format which we use in Manchester. The older one that came from the 1960s is a precipitins test, and there are ELISA tests, and they've got variable sensitivity specificity, but it's pretty good. And we studied that for multiple different tests here, and the best one actually was a Siemens test on this with about a 96% sensitivity, 98% specificity. But very recently, just last year, a lateral flow test was developed and is now sold. And here you can see examples of this. So you put your serum into the well, you wait 20 to 30 minutes, it comes down, you get a control line telling you that the test is performing correctly, and then you have a positive, positive, negative, positive, negative. And this test is really, it's quite simple, it's not expensive, and it really performs quite well, around a 90% sensitivity and nearly 99% specificity. And that compares, it's better than the big machine that I showed you in our hands, although we haven't done a head-to-head. So you treat these patients, we treat these patients normally with oral azole therapy, itraconazole, 400 milligrams a day, and we measure levels, or voriconazole, a little lower dose in older people and very small people, and a larger dose in younger people and bigger people. And then we also use posaconazole, but I guess you won't use that because it's forbiddingly expensive at the moment. And the recommendations in our guidelines were pretty good, although there have been randomized studies. They haven't been long-term and large, which is why they end up with a 2, although there are randomized studies for both voriconazole and itraconazole. Now, you probably already know this, but there are lots and lots and lots of drug interactions with itraconazole and voriconazole. They're amongst the agents that you use with the highest number of drug interactions. So about a year ago, we had over 2,000, and 400 of these are severe drug interactions. So there's an app online that you can download, antifungal interactions, and you can check what the patient's on, and that is helpful in terms of looking after these patients. So once you start them on therapy, the next question is, well, how long do I have to keep going? And the recommendation was to give at least 6 months of therapy. If they manage well and they're doing well and they can afford it, and you can, and the system can afford it, then we would keep patients on therapy. But things that limit itraconazole are peripheral neuropathy, and some patients get a lot of ankle swelling and high blood pressure. And with voriconazole, which won't be a problem for you in black skins, is they get photosensitivity and dry eyes and dry lips, and that can be a limiting factor, and also peripheral neuropathy as well. And of course, in both of them, we need to check the liver tests. And if you can't take, or they fail the azoles, the oral azoles, then we use intravenous therapy with micafungin, amphotericin, or caspofungin. And one of these, given for periods of 3 or 4 weeks, helps these patients a lot in terms of improvement. And we've had patients who failed itraconazole, had a course of amphotericin and gone back onto itraconazole, and then been maintained well for long periods of time. So that's another strategy. So today is World Aspergillosis Day, and it's our second World Aspergillosis Day, and it's really wonderful to be speaking to you today. I'm speaking very much with my GAFI hat on. GAFI is out there to try to minimize the burden of fungal diseases and also the morbidity and mortality associated with fungal diseases. And so we really do need to make sure that everybody has got access to diagnosis and medicine across the world, and that includes Ghana. And so I'm very happy to answer questions. We will set up an online system to address questions that you may have, and I'm also willing to take emails or other comments if that would be helpful for you in trying to get Ghana really up to speed with trying to do the best that they possibly can with the patients with these complex problems. Many thanks.